Good morning and welcome to our UBC Learning Circle, Peace of Mind for Rural Maternity in BC with real-time virtual supports, maternity and babies advice line with Dr. Amy Sawchuck and Dr. Keeve de Villiers. Today's conversation is presented in partnership with the Center for Excellence in Indigenous Health. We'd like to thank the First Nation Health Authority for generously funding the UBC Learning Circle and allowing us to have these conversations. And before we formally begin, I'd like to acknowledge with gratitude that I'm joining you from the unceded territories of the Musqueam, Squamish, and Tsleil-Waututh nations. Please feel free to introduce yourselves in the chat box. And for those of you who don't know me, my name is Sarain Squawkin. I'm the Learning Circle manager. I am Syilx Okanagan on my mother's side and Hickory Apache and Belgian on my father's side. And I'll be your moderator for today's discussion. And joining us working behind the scenes is Cynthia, our production coordinator. She'll be in the background interacting with everyone in the chat. And finally, before we get into today's discussion, I'll provide a gentle heads up that the topics covered may be sensitive or emotionally triggering. Please make sure that you're looking after yourself, and if at any point in time you need to talk to a friend, elder, or counselor, don't hesitate to do so. We have some prompts in the chat if you need additional support. Now I'll turn it over to our guest.
There we go. So I'm Dr. Keeve de Villiers. I'm one of the maternity and baby advice line physician leads, along with Dr. Amy Sawchuk, who I'll introduce herself in just a sec. I'd like to acknowledge I'm calling in today from the territory, the unceded territory of the Sawchuk Nation, or more specifically in Tekem-Loops, Sawchuk, where I am also a settler and an uninvited guest. I've been working in maternity for going about just over 8 years now, of which I spent the majority of that working in rural, and I continue to spend time working in rural maternity and locuming, as well as doing general family practice. I'll hand it over to Amy.
Thanks, Keeve. My name's Amy Sawchuk, and thank you for inviting me today to share at the UBC Learning Circle. I'm calling in today from the traditional territory of the Tla'amin Nation on the Sunshine Coast, also known as Paul River. I am a family physician with a special interest in maternity and continue to practice here locally as a full-service family physician, as well as seeing prenatal delivering babies and supporting postnatal. And I work closely with Keeve to support this maternity and babies service that we're going to speak about today. We're greatly excited to share with all the work we do to support rural communities in BC. And you'll learn more about the service, and I'll turn it back to Keeve to begin our presentation. Thank you.
All right, so I also just want to thank everyone for joining us today and for UBC for this opportunity. I think it's really exciting for us to be able to share with you guys some of the work that we've been doing and some of the things that have been developing in this space. All of the providers that are involved with this service are passionate about rural care and about making rural care better. And this was one of the things that has come out of the pandemic as, we think, a great success in helping address some of this need. Could I ask we move on, Sarain? Very good. So today, we're going to be talking about a number of different things. Specifically, this is around one of the peer-to-peer pathways, which I'll explain in just a second, specific to maternity. If you'll go to the next slide for me there. Just to put it up there again. And next slide for me. So RTVS as an organization, or the Real-Time Virtual Support Network, provides a number of different pathways. Specifically, there are some peer-to-peer pathways, which we're going to be talking about a little bit more today, as well as some patient-facing pathways. And these were created in 2020, mostly in response to a long-standing need to address some of the inequity faced by rural communities. And the goal that all of us share across all of these pathways is to increase access and improve rural care. Now, we're not going to be talking very much about the patient-facing pathways, so I might just mention them here in that we have large overlap with the First Nations Health Authority, as well as many of the other health authorities, including Northern Health, where we do the majority of our work in those communities. Some of you may be familiar with the First Nations Virtual Doctor of the Day program, which is housed within RTVS, as well as the Heidi line, which is where somebody can call in and get immediate advice. These, again, all share the same impetus in that we were trying to meet the need of inequitable access and allow people the ability to get help when they needed it. When it comes to the peer-to-peer pathways, these were designed specifically to assist providers who are already working in community. And if we'll go to the next slide there for me, specifically, we created three, or initially in 2020, three lines were created. The majority of our calls are placed through to the Rudy line, which is staffed by physicians who mostly work in emergency medicine, but many of them are also rural family physicians and have the ability to provide just-in-time advice, i.e. when a provider is working in community and needs some advice, they can call. Now, this means often, and a majority of the work that they sometimes see, it comes from rural nursing stations or remote nursing stations, where a critical patient may present. And Rudy physicians are able to help stabilize, help give advice, help prescribe medications, all at the time that advice is needed. And this includes running things like virtual resuscitations for people who come in with trauma, as well as arranging for transfer as required and making those connections. And in exactly the same way, the Charlie line is staffed by pediatricians and provide advice on children or the acute care of children, as well as just general advice. Now, more specifically today, in terms of the maternity line, which is what Amy and myself work in, we are staffed by a group of family physicians with special interests in obstetrics or in maternity, working with the delivery of babies anytime through the pregnancy, as well as in the immediate postpartum period, as well as in the care of young infants in the neonatal period. We all work in or have experience in rural sites and work within obstetrics to give high quality advice and help patients get the care that they need just in time, as well as arranging for transfers when required. Next slide for me. Now, RTVS also has a number of other quick reply pathways for specifically some specialist areas that are sometimes really difficult to get advice on. Even in an urban setting, sometimes to get help about a patient in any of these areas can sometimes be quite troubling, and that is simply compounded when you're working in rural and remote locations. And so the idea behind the quick reply pathways is that a provider can reach out to one of the specialists in these areas and usually get same-day advice about a patient. Next slide, please. Now, I don't think that it is news to anyone that rural medicine functions a little differently to what we would see in an urban setting. And a lot of this is due to resourcing. Some of it is certainly due to the geography of British Columbia, which creates long distances between communities and higher levels of care or bigger hospitals where the specialized services usually reside. And the context for rural is so important in terms of how care is delivered, and working within a system where we have big struggles in terms of resourcing sites appropriately, having appropriate human resources in terms of providing adequate nursing, physician, or just healthcare providers is a big challenge. And a lot of the work that we do is aimed at providing care within the lens of what makes sense in rural. Next slide. Now, it's very clear that there is inequitable access between rural and remote communities and urban communities. And for those of us who work in rural areas, this is quite obvious, but it's not always that obvious for people who've never even been to many of these communities. There is a big need to provide care in a manner that is informed, so culturally safe and trauma-informed. And as we know, turnover in rural for providers is big. People struggle to often stay in community. And in an ideal situation, we would have enough providers in every community all across BC. But given that that's not the case, this line aims to provide support to those providers to make their lives a little easier, to make working in an under-resourced setting that much easier to continue and to avoid provider burnout. Ultimately, retention issue or recruitment issues to rural sites is also very difficult. And a key tenet of this program was to provide surety to rural providers who are going to smaller sites that they would have help if they needed it and not feel completely isolated. Next slide for me. Now, what does that look like? So some of the work or all of the work that we do is provided via telehealth. Mostly our platform of choice is Zoom, providing video calls, but it also means that simply phoning us is also possible as we have a provider available 24/7. A wonderful feature of this service is the ability to see the patient in front of you. And so if there is a need, most of the work just is advice to providers who are looking after the patients. But if there is a need, and certainly when it comes to things like emergency department work, being able to visualize the patient in front of you as things are happening in real time, as well as with young babies when a resuscitation is potentially happening, having Zoom immediately there and having access to, we have some technology pieces in place at many of the nursing stations in the form of a virtual care cart that takes the form of a computer with a camera that we can adjust, really helps to give the providers context of what's happening on the ground at the time and improve the level of care that we can provide. Now, any of the providers doing the service, when we are on call, we're available 24/7. We're not working anywhere else. We're entirely dedicated to providing the service to rural communities. All of our providers have context in rural and understand what it means to work outside of big centers, as well as the challenges that sometimes come with that, including transport and making those connections in terms of getting people to where they need to go. We basically provide access to advice in any type of call or any type of presentation. In the greater basket of RTVS, that would mean anybody that would walk into an emergency department or into a walk-in clinic, more specifically to the maternity and baby advice line, or MaBAL. That would mean anything related to maternity or women's health. And that would go from anything as simple as questions on antenatal care or basic things like prescriptions, to ordering tests or helping providers make those connections to refer people to delivery sites, that people get access to care during their pregnancy and postpartum. Now, for the providers who call into the line, these are also accredited for continuous learning credits that they can claim as time spent improving their practice. And most importantly, our aim is to provide a service that is friendly and accessible when providers need it. Next slide. Now, this slide just represents the sort of a cross-section of all the services that are provided within RTVS, or some of them at least, and just the timeline. As you can see, the RTVS was really came to fruition in April of 2020. And it was really the vacuum that was created by the pandemic that helped create the environment that suddenly everyone said, well, what are we going to do when we can't move people from communities? How are we going to not leave rural behind completely? And a number of these a number of our pathways were designed specifically to address this need. And as you can see, mostly in 2020 is where most of the core services got up and running. I'm not going to delve too much into the other pathways, but simply to say here that RTVS tried or continues to try and fill a very, very big gap. And that means that as needs come up, the organization has been responsive in trying to respond to those, including in advice around COVID medications and our ongoing hope to set up a critical care line as well. Next slide. Now, for providers working in rural, it's a common experience to have difficulty phoning your site. And so in the past, or even in many places still today, the standard care pathway is if you have a patient that you are unsure about or that you need transport for, you pick up the phone to your regional center or your referral center, and you need to speak to somebody there who will accept your patient and then arrange the transfer for. And many times these regional sites are also overburdened and understaffed. And there is certainly a feeling amongst many providers, and I personally have also experienced this, that it can sometimes be difficult to get friendly in-time advice if those providers at your referral site are also overburdened. And this is exactly the type of situation that we aim to avoid. And so the services that we provide are designed to be friendly, and the culture that we try and have is one of how can we help? Giving providers that surety that somebody who is a peer, who understands their context, will be available to simply give them advice or just reassure them that what they're doing is the right thing, or when they need more help, to be an extra set of hands to help with the transfer of a patient or help move patients through the healthcare system. Next slide, please. And this one is fairly self-explanatory. Next slide. Now, what are some of the things that people call us about? So we get anything from basic questions regarding anything in the prenatal or postnatal period, so pregnancy, labor, delivery. We have delivered babies on the service in sites that don't normally do deliveries, or for patients who presented emergently, to help providers on site with what they need to do when they feel inexperienced or under-resourced. Next slide, please. We can help with things such as prescriptions or just basic advice. Next slide. Or any questions about antenatal testing or setting up care. And a lot of, I don't think that, well, it's certainly not news to me, but anybody working in healthcare, maternity is unfortunately an area of medicine or healthcare that is often underfunded. And there is such a huge need for people to be connected with adequate and good care. And part of the work that we do is to help connect people to the existing structures, especially if they are far away from centers that normally do deliveries, and to provide safe care in these instances. Next slide. MaBAL providers are also all knowledgeable on postpartum care of moms and young infants, and this includes advice on breastfeeding and infant feeding in that critical period just following delivery. Next slide. And lastly, the MaBAL physicians are also all available to help with any kind of questions around women's health and family planning issues. And we get a wide range of questions, but ultimately, one of our biggest, one of our biggest benefits has been to assist the service in providing access to people with knowledge around women's health, which is sometimes, again, an area of medicine that many providers are not necessarily that well versed in. Next slide. In some circumstances, the MaBAL line has also been called on to provide additional support. And so we've had some of our smaller communities requiring assistance when they haven't had the staffing, either from nursing or from physicians, to be able to manage deliveries and maternity care at their site. And MaBAL physicians have then been available to the physicians who are still staffing the emergency department or other providers at the site who may not be knowledgeable in maternity care to give us a call to help make a plan for how to divert patients or how to safely care for patients that present to their site in need of help. Next slide. Now, RTVS as an organization takes cultural safety and trauma-informed care very seriously. And this, the central tenet of the work that we do and the way that the service has been set up is around how important it is to provide culturally safe care. Now, this diagram was developed for RTVS and is simply a showcase of some of the work that has been done by the organization and some of the work that is ongoing in terms of how we are training our providers to be aware of this, and I'll just mention sort of in passing that, as an organization, this is the first organization I've ever worked in where cultural safety and humility has been put right at the forefront of some of the work that we do in terms of training providers adequately, providing opportunities for the providers on our service to take part in cultural humility training, and ensuring that this is really at the forefront of when people call us, that we have this context. And you'll see there the RTVS backpack is an image that was created to try and give some substance to the things that we try and carry with us every time we go into a conversation. And this journey, of course, is ongoing. Next slide. Now, to give some context, this is just a map of where RTVS has had points of contact across the province. So this is where we are receiving the calls from. We have some sites that call us quite frequently and some sites that call us less often. And part of the work that we're doing and part of the work today is to get the word out about the service being available to communities wherever they are, or to providers wherever they are, that they can give us a call if they need help. We are always available and want to hear from them. Next slide. Now, on a personal note, why providers get involved with this service is obviously multifaceted, but it is ultimately a way to get back to be able to provide ongoing care to rural communities, for many of whom we have a passion, and which is why we're involved in this service. Like I said before, there's no doubt that maternity is vastly underfunded and under-resourced, and this extends to the number of providers who are willing to do this. And this is, in terms of maternity and rural care, this is a way that rural care has been able to utilize technology to really be at the forefront of changing the way that medicine is done, and we've been able to be quite nimble in utilizing new technology that many of the bigger sites and urban centers haven't been able to do. Now, RTVS as an organization is doing really exciting work and has been recognized both within Canada and internationally as doing something that is new and utilizing technology in a way to support rural communities that hasn't really been done before, and certainly not on the scale that we're doing it right now. And so really being at the I wanted to use the word edge of care, but that's that's exactly the video that we're going to be playing for everyone on the call today, to showcase some of the work that RTVS has been doing, but to be really at the cutting edge of how we are doing medicine is very exciting and a reason that people get involved. Next slide. Now, part of the work that we're doing as well is ongoing outreach to some of the communities that reach out to us. There is a big need for ongoing technological support and providing the tools that communities and providers need to get a hold of us. And so that middle picture, you'll see those are one of the cots that we have in some of the communities that we work with, that has the camera on top that a provider working on our service can use to pan around the room and see patients in front of them, or simply just be a point to look at the patient when the provider's face is up on the screen, and provide something akin to a two-way conversation that the physician and the provider in the room can have direct contact with the patient. Next slide. So we want to take this opportunity now to play for everyone a video that was developed for RTVS to showcase some of the really important work and some of its impact that it's had in rural communities. And I'll let the video speak for itself. Every time I watch that, it's so inspiring to hear some of the work that we've, to be a part of this really, really important work. If we could get the slideshow back up, got a couple more to go there. I'm gonna, there'll be plenty of opportunity to ask questions at the end. But I certainly hope that that's left you with a bit of a sense of some of the work that we've been doing within RTVS. And I think that also showcases very clearly for some of the physicians on there and for myself why we do this work and why it's so impactful. But to continue to color in the picture for everyone, some of the things that we've been doing here, a lot of it is about supporting rural providers and making rural care better and assisting providers in feeling supported. Next slide. Thought it might be helpful just to mention some of the cases that we've done, some of the support we've given, and just to highlight again to everybody on the call that the things or the providers that we support range anywhere from nurses to nurse practitioners to midwives to other physicians. Basically, anybody who is finding themselves in a situation where they need an extra pair of eyes and just asking for some advice. Next slide. And this obviously extends, very importantly, to the work that MaBAL does into helping moms and babies and assisting in getting sometimes what could have been a very traumatic situation, or at least sometimes what is a traumatic situation for things like a preterm birth, and helping that go that much smoother, that we have safety for mom and for baby. Next slide. So more so in summary, the things that we are trying to achieve here are really to provide an umbrella service for rural providers to receive support, that they can do it when they need it, so that it is on demand and just in time, that service is friendly and collegial, and that there is a low barrier for people to access it. This obviously, the knock-on effect of this would be to prevent provider burnout and additional fatigue. And we try to be as adaptive as possible to the needs of the community and of rural healthcare in general. Next slide. It, of course, does not come without challenges. And this, particularly, we are a platform, or at least we're an organization very dependent on a technological platform. So as we all know, when the electricity is not working or when there is no internet, these can obviously make this a lot more difficult. Many of the communities that we help sometimes don't even have consistent access to a phone line. And these are all things that continue to hamper some of the work that we're doing. But mostly, I think I'd leave you with these challenges are all part of what makes this work so interesting. Next slide. As an organization, we've certainly grown over the last 4 years or roughly 4 years that we've been doing this. A lot of it has been to be flexible and to be nimble, and certainly having the privilege of doing something that is new and something that hasn't really been done before has meant that we could iterate as we go along. To keep it flexible. And I think it's really important, and what I want to leave everyone with is that at the heart of this service, we put relationship, especially for provider to provider and provider to community, but that we as a service want to build these relationships with communities. And the relationship given in a trauma-informed and a culturally safe context is really what makes this a success. Because there have been other iterations of something like this done in other parts of Canada that haven't been successful. And part of the reason that this has been a success is because the desire and the motivation is there to start from grassroots. And again, when it starts with a relationship where we are invited into a community, that's where our success lies. Next slide. So we're going to have an opportunity if anybody wants to ask some questions. Hopefully there's some more things that we could make clear to everybody. I think, I'll open up the floor. Or perhaps maybe we should take an opportunity, if there was anything in the chat, maybe just to go through that before we open it up completely. Amy?
Yeah, thanks, Keeve. I've been answering a few questions live here in the Q&A, so I appreciate the questions that have come in so far. Thank you so much. This is a fascinating webinar. For the panelists, in your view, what has been some of the biggest success stories of MaBAL, and is there one that sticks out to you? I typed in an answer there briefly, which I can elaborate on, but as a provider, having worked in rural, I worked in Whitehorse in the Yukon for 7 years and serviced a lot of communities, predominantly Indigenous communities in the north. And one of the biggest things we noted was this, speaking of the inequity of care that exists in some of these communities. And it is because of a challenge with providers going to community to provide service. So it was the dream that came out of it that if providers in the community, nurses, nurse practitioners, midwives, physicians visiting who didn't do maternity care often could call a provider such as Keeve or I to ask their questions when they first found out the patient was pregnant, would this improve or change outcome? And this is what we are seeing. So a call I got, for example, last week was a patient who was on ADHD medications, and the physician just wanted to run it by me whether this was a good idea through the pregnancy. So we had a fulsome discussion on where that patient was coming from, because the answer is not just yes or no. The answer is much more complex. And in that conversation, we reviewed all the patient's medications and realized she was on seizure medications, and that the dose of that medication hadn't been up titrated in pregnancy, and she was having breakthrough seizures. So again, we reviewed how that would be a good idea to increase the dose and check the level and things like that. So those are the small, what some people see as small things and I see as a big impact. In that rate from the moment we get a positive pregnancy test, we can review the history of the patient and hopefully improve their experience throughout their pregnancy based on the medications they're already on. There's obviously the stories that Keeve and I can share where there's a big event, for example, the birth that the provider in the video spoke of in community. There's also the near miss. Recently, a patient up in a northern community, a very premature delivery around 32 weeks, got to a larger center and delivered within 20 minutes of arrival in the community. And MaBAL was very much involved in advocating for that community to get a plane there, get transferred, and get that woman to a higher level of care. And we believe the baby survived because of our involvement and our advocacy work to get them to a higher level center for delivery. So we do see our impact, I would say, daily, weekly, monthly, and it's not always the big cases, but often the little things that are happening. So the second question was, can nurse practitioners or outpost nurses reach out to us? And I would say with 100% yes, please. So anyone providing care in community is welcome to call us. And we have a website, real-time virtual support, that you can, the phone numbers are there, the Zoom contacts are there. Please reach out to us and we'd be more than happy to support. We've supported paramedics on the ground. We're starting to develop relationships with search and rescue. We get support from, we support midwives. And the whole premise is that we are happy to hear your call. We will be friendly. We promise there is no silly questions. I've had a very, very experienced, competent midwife practicing out in community call me, and she was awake for 24 hours, which, as you know, by 24 hours, you're not thinking clearly. And she knew exactly what to do for care on transport and what medication to give the mom, but she just wanted a sobering second thought of a physician who hadn't been awake or for 24 hours to provide, to answer her question and just say, should I give that morphine? And of course, the answer was, you know exactly what to do, but she just wanted a second opinion. So we're here for second opinions. We're here for just run it by a friend. We're here for colleagues. And for those patients that are out there on our webinar hearing us and hearing this, it's also okay to advocate for your center or the nurse supporting you or the nurse practitioner midwife that if you want them to get a second opinion or call us to say, please, do you mind calling this program that I heard about, where you could call them via Zoom and just get a second opinion, that's of course welcomed as well. So those are some of the questions that I've seen in the chat so far, Keeve. Any further questions we're happy to answer.
We just have a few from just like that we've created on the Learning Circle. So we were just wondering, like, how big is your team, and is there plans to expand to further communities in BC?
Do you want to take that one, Amy?
Sure. Yeah. So our team is currently 13 family physicians who do obstetrics. That allows us to do about 2 call shifts, 2 24-hour call shifts a month on the service. We are open to supporting any community, any rural community in BC. Currently, we do not support our urban centers. And the reason for that is they already have access to great support. However, if we do get a call from an urban center, of course, we're not going to turn them down. So, but right now our focus is on supporting these underserved rural communities. So any community in BC is currently eligible to call us for support. There's nobody excluded from BC.
Our next question is, how do you get the proper equipment to do some of the care that you were talking about in your presentation, but also shown in the video? Because some of the I think stations had like special equipment or whatnot to show what's the patient and the provider are experiencing. Whereas like if it's, let's say it's a newer community and they don't have that, like what's the process of setting that up for them?
All you need is access to the internet. So personal cell phone, laptop, iPad, your own personal device. I know some of our providers aren't super keen to use their own cell phone, but most of our calls come from individual cell phone nurses who have the Zoom app on their phone. So you can even just use a phone number. We'll share that link. Rebecca, kindly, our communications expert, has shared the link for the website, but all you need is a phone number or a Zoom link, which is in there. You can just download Zoom onto your personal cell phone, iPad in your center, and we will communicate via that way or on a phone number. You don't need any special technology like carts or anything like that. You do need internet access or a phone line in your community to call us.
And our next question is just how do you ensure that your line through Zoom is a safe one? I know there's been like Zoom bombing in the past, just with people accessing links or whatnot. Like, how do you make sure that the link and everything is safe and embedded and whatnot?
Rebecca?
Do you want me? Yeah.
Rebecca, yeah.
Hi, I'm Rebecca. I support Amy and Keeve from the Rural Coordination Center of BC. The instance of Zoom that we use is actually a Zoom for healthcare. So it's like FOIPA and FIPA and whatever the other one's, PIPA, I think, approved. So all of the, there's no way to record anything on the Zoom call. So it's all sort of approved by the ministry in terms of nobody could just kind of hop on the call or anything like that. So there'd be no Zoom bombing during any of the calls.
Great. We just got another question. It's a little bit longer. One of our participants just says, "Hi, Dr. Sawchuk. I'm also in Gathet. I don't know.
Gathet, yeah.
Pronounce that right. Yeah, Gathet. Yeah, and this person has previously worked as a doula in this community before working with Métis Nation of BC, and they're wondering if you've seen any changes in the amount of patients leaving community to give birth or immediately afterwards here in other communities."
Yeah, so our service at this time is directly linking people to still go through their routine standards of care, which is transfer at a community for delivery in those communities that don't currently support delivery in them. So we have not changed or affected birthing in community. However, we are very much linked in with FNHA and their current work, which is to examine and re-examine bringing birthing back to community. So all that work is currently still being led out by the First Nations Health Authority and their excellent team. There's been a recent report that's come out with regards to what will need to occur to bring birthing back to community. That's very much the top of their work, and MaBAL will continue to work alongside with First Nations Health Authority to support these initiatives. But at this time, we're not working to change the current referral patterns that are already present for communities. We're there to support what is currently happening. And that's where I think our very large messaging is. It's really important. I think the excellence of our care comes from listening and hearing where communities are at present and not trying to step in to change what they do. The people in community, the patients, the providers, the people on the ground know best what is occurring in their community, what they do with excellence. We're just there to hear that and to support that in the best way we can and connect them as needed. We don't work to change what they're currently doing. We're willing to advocate and help and support as we can, but we don't want to change current practice.
Just got another question. What is the report on bringing birth back to community? This person's curious and would like to read if available. Thanks.
Yeah, I'm not sure it's public at this time. It's within the First Nations Health Authority, and maybe I'm privy to that inside report at this time. I don't think it's been publicly announced. Yeah, so unfortunately, I think the best way to access that bringing birthing to community report would be through the FNHA Health Authority at this time.
And last question that we have right now is how would you get involved in this if you were a new doctor or if you just learned about the program through this webinar? I know there's probably a lot of healthcare practitioners that may want to be a part of this. Like, do you guys have any process or whatnot to get involved or like help support this program?
Yeah, for sure. We're always doing recruitment. We have a formal process through the Rural Coordination Centre BC. So one could reach out to Keeve or I, and we basically have an application like you would for a routine role and job. We select providers who have experience with rural, as we've really focused on here, and an understanding of working with Indigenous communities, as many of our calls come from Indigenous communities. And then obviously the providers must have a experience in obstetrics and the prenatal, postnatal women's health that we provide on the service. And then they must be open to continuing on this journey with us of cultural safety and sensitivity training. So that is an obligation to provide service in our service, and a personality that goes along with, wanting to help, wanting to serve. How can I help you? And really working towards this culture change. So if any of the new physicians out there are interested in providing or becoming a part of our service, we welcome them to reach out to Keeve or I, or our team for sure. And the way that our service is being spread throughout the community, I mean, originally we had about, when we first came on board, Rebecca might be able to speak to the numbers, but we had 15 communities reaching out to us. We're over 100 communities now who call us on a somewhat regular basis for support, and the word just gets spread through positive experience, through webinars such as being invited to this one. We do, as you saw, we do outreach to community. So that picture of in front of the airplane was myself and a midwife flying into Quedacha to meet community and hear, because when you visit these communities in person, you really begin to understand the challenges of transport that comes for these communities in the service. So us going out, spreading our what services we provide, and hopefully will transpire. A lot of the locums that travel to these rural communities, both travel nurses, traveling physicians, they travel to multiple different communities, so they get to know about our service, and then they access from all the communities that they're in. As well, we definitely reach out to our residency programs, so the family practice residency programs, to make them aware of our services, because we know that they'll be the next generation of physicians that are out in community. And I speak from firsthand experience that when I was out in all these rural communities as a brand new grad in my second year of practice, I could have so used a service like real-time virtual support to call on every shift that I did in the rural emergencies rooms, because it was so scary to be out there and to trying to learn on the ground. So we're so excited that this service has been stood up. And I think that's why many of us have worked in these communities really have passion for this, because we know what it's like to be on that other end of the phone.
And that looks like our last question. Do you have any closing remarks or any words of encouragement for people who are either a little afraid to access or whatnot, to encourage them to reach out, even if it's just a test call or whatnot?
Yeah, I'd say just give it a whirl. That's we get many test calls in our day. So just reaching out. I don't actually have a patient right now, but I just wanted to test it and see if there was actually a human like you, Amy, on the other end that was going to be there. And I just wanted to check or see if we were friendly or not. But I promise you we'll answer with a smiling face, and we promise, we're just here to help. And there is no silly question. So please give us a call and give it a try. I hope that we hear from most of you in the next few weeks.
Great. Thank you so much. Any last words, Keeve?
Yeah, no, I mean, thanks everyone for joining us today. I'm glad. I'm really glad that we could share something that we find obviously very exciting, and we think it's going to make a huge difference to care going forward over the next years and decades to come, and hopefully is only the beginning of improving rural care. And as I said before, feel free to reach out to us if there are any other questions. If there are any providers that you know of that want to reach out to us either to test or to join the service, send us an email and we can always take it from there. But thanks for joining us.
And I would just add as well that we can provide simulations to sites. So if maybe you're not a nurse or whatever, you're connected to the team more broadly, and you think it would be interesting for your team to see what it'd be like to bring in a MaBAL provider, you can actually book a simulation and they can show you what it's like with your whole team, so everyone can kind of learn together. Thank you.
That's great. Thank you so much. Just thank you to all our guests and to everyone for joining us today. Thank you so much, Keeve, Amy, Rebecca, for the amazing discussion and learning about your guys' amazing program. I'm sure everyone is eager to learn more how to support or even bring this to their community or share this with their community. And yeah, so thank you so much. And just before we end the webinar, we'd love to bring your attention to our upcoming learning circles. We have Walking Like Warriors, that's on April 2nd. That's with Alana Cook and Keenan Keller. And then we have Unseated and Undefeated, that's also with Alana Cook, and that is on April 16th. And then we have Trauma Informed Healing Center Community Wellness, that is on April 17th. And all of our webinars are free to sign up for on our website at www.learningscircle.ubc.ca, and sign up for our newsletter. The link will be in the chat. And thank you for everyone for joining us today. We look forward to seeing everyone at our next Learning Circle. Lim, thank you.